Okay, so today we're going to start with the first apprehension test, then Jobe's subluxation and relocation. So first I've got my patient's arm here, I'm going to support under the elbow. I'm bringing them out into 90 degrees of shoulder abduction, and then I'm going to give them some external rotation at the glenohumeral joint. I'm kind of keeping an eye on my patient's face, looking for any cringes like she's doing now, or any wide eyes, something that just like displays shock, like this position typically would cause them pain. That would be a little bit of an indicator for me personally. But then to continue the test, I would give just a little bit of overpressure, asking my patient if there's any pain in the anterior shoulder, which could indicate some type of laxity or weakness, or maybe even a lesion in the anterior capsule of the glenohumeral joint. Next, for Jobe's subluxation and relocation, I've kind of got my patient in the same position, 90 degrees of shoulder abduction and external rotation. And I'm going to start with the subluxation, Jobe's subluxation. So I'm going to bring my arm, or my hand, posterior to the patient's glenohumeral joint and provide an anterior translation force. And I'm asking my patient if they're noticing any pain anterior or posterior here. Anterior pain could implicate, again, that there is some weakening or laxity of that anterior capsule. Posterior pain could indicate an internal impingement, and we could be sucking in some of those rotator cuffs into that space being generated in the glenohumeral joint. Second, I'm going to do the Jobe's relocation, pushing down, giving a posterior translation force on the glenohumeral joint. And if we notice that there was anterior pain with the previous Jobe's subluxation that diminishes with the Jobe's relocation, this posterior translation, that would just further indicate the anterior capsule.